Hello friends, in this lecture video, I will discuss about anti-Nmosd, that is neuromyelitis optica, a spectrum disorder, and MOGAD, that is myelin oligodendrocytes glycoprotein associated disorders. The content of my lecture include pathophysiology of anti-Nmosd and MOGAD, diagnostic criteria, optic neuritis findings, myelitis in the patients with Nmosd and MOGAD, brain lesions in these patients, laboratory features, and the treatment protocols in the patients with Nmosd and MOGAD. Pathophysiology of Nmosd and MOGAD include in Nmosd interleukin 6, which is the inflammatory cytokines which promotes the differentiation of B cells into aquaporin secreting IgG plasmoblast. This IgG plasmoblast which is formed crosses the blood-brain barriers and binds to the astrocytes, which activates complements cascades with the release of anaphylotoxins leading to the damage of astrocytes, which is the main target cells in this Nmosd. Oligodendrocytes are not being damaged in this disease. And this figure summarizes the pathophysiology that we have explained, that is interleukin 6 acts on the B cells to promote it into plasmoblast secreting IgG, aquaporins secreting IgG. These aquaporin IgG crosses blood-brain barriers, binds to the astrocyte leading to the damage, and oligodendrocytes being not affected. Whereas in MOGAD, interleukin 6 promotes the differentiation of B cells into MOG secreting IgG plasmoblast. This MOG IgG crosses the blood-brain barrier and binds to the oligodendrocytes, as well as it activates the complement leading to further damage of these cells, that is oligodendrocytes, which is the main pathophysiology responsible for MOGAD. And this figure summarizes the pathophysiology that we have discussed earlier, that is B cells are differentiated into MOG secreting IgG, which crosses the blood-brain barriers, binds to the oligodendrocytes leading to the damage and leading to the manifestation of MOGAD. This table summarizes the pathophysiology in these two diseases, which is the demyelinating disease. In Nmosd, the target cells being astrocytes, which we have discussed earlier, whereas in MOGAD, the target cells is oligodendrocytes. The site of antibody production in MOGAD is periphery as well as central. The cytokines which is responsible for the manifestation of this disease is the interleukin 6, interleukin 10, 17A, granulocyte colony stimulating factors, tumor necrosis factors. Astrocytes being damaged in Nmosd, whereas oligodendrocytes are damaged in MOGAD. Glial fibrillary acid proteins are high in Nmosd, whereas myelin basic proteins are high in the patients with MOGAD. Now, the diagnostic criteria of Nmosd and MOGAD include, we will study the diagnostic criteria in a comparative manner. What is the similarity and what are the differences in the diagnostic criteria? These two diseases have core clinical characteristics, antibody positivity and exclusion of alternate diagnosis. The core clinical criteria in Nmosd include optic neuritis, acute myelitis, area prostrema syndrome, acute brainstem syndromes, symptomatic narcolepsy or acute diencephalic clinical syndromes with Nmosd, typically with MRI lesions of diencephalons, symptomatic cerebellar syndromes with Nmosd, typically with brain lesions. These are the core clinical features in Nmosd. Whereas in MOGAD, the core clinical features include optic neuritis, myelitis, brain stems or cerebellar deficits, ADEM, cerebral monofocal or polyfocal deficits, cerebral cortical encephalitis with seizure. These are the core clinical features in MOGAD. Whereas the antibody positivity in Nmosd include aquaporin secreting IgGs, aquaporin IgG being positive in Nmosd, whereas in MOGAD, MOG secreting IgG is positive, which is detected by cell waste assay. For a clear positivity, the titer should be greater than 1:100, then no additional features is required. For low positivity, that is titer with greater than 1:10 to less than 1:100, positive without reported titers or serum negative but CSF positive, then two additional features should be included. That include aquaporin IgG should be seronegative and one or more of the other clinical or MRI features should be present. What are these MRI features? In these two diseases, the MRI features in MOGAD include optic neuritis, myelitis, brainstem or cerebellar syndromes. Whereas in Nmosd, the additional MRI features include acute optic neuritis, acute myelitis and area prostrema syndromes. We will discuss about these features in these lesions in the subsequent slides. Then third criteria should be exclusion of other diagnoses, including multiple sclerosis in Nmosd as well as in MOGAD. So to classify it as MOGAD, the fulfillment of all of the following: first, second and third. First is the core clinical, second one is antibody positivity and third is the exclusion of other diagnosis. For Nmosd, the diagnostic criteria, we have the two diagnostic criteria. First diagnostic criteria include Nmosd with aquaporin secreting IgG aquaporin positivity and Nmosd without aquaporin 4 IgG or unknown aquaporin 4 IgG status. The diagnostic criteria for Nmosd include with aquaporin 4 IgG include at least one core clinical characteristics, that is optic neuritis, myelitis or area prostrema syndrome with positive test for aquaporin 4 IgG detected by cell waste assay and exclusion of alternate diagnosis. Then diagnostic criteria for Nmosd without aquaporin 4 IgG or unknown aquaporin 4 IgG status include at least two core clinical characteristics occurring as a result of one or more clinical attacks and meeting all of the following requirement, that is two core clinical characteristics with at least one clinical attacks and other other criteria should be fulfilled. That is, one core clinical characteristics must be optic neuritis, acute myelitis with longitudinally extensive transverse myelitis or area proxima syndrome. Second one is dissemination in a space, that is two or more clinical characteristics. Third is the fulfillment of MRI requirements, and four being negative test for aquaporin 4 IgG detected by cell-based assay and exclusion of alternate diagnosis. So, to classify it as seronegative Nmosd, two core clinical characteristics with one attack and other requirements should be fulfilled. That is, one core clinical characteristic must be optic neuritis, acute myelitis with longitudinally extensive transverse myelitis or area proxima syndrome, as well as dissemination in a space, additional MRI requirement with negative test for aquaporin 4 IgG and exclusion of alternate diagnosis. Then we will classify it as seronegative Nmosd, neuromyelitis optica spectrum disorders. Then optic neuritis in the patients with Nmosd and MOGAD. What are the characteristics in the optic neuritis in this disease? Optic neuritis in Nmosd include bilateral optic neuritis involving chiasma. Here we can see that in Nmosd, bilateral involvement of the optic nerves with the involvement of chiasma, and lesion is posterior to the optic chiasma, which is characteristic in Nmosd, which can be seen in this MRI also. Whereas in MOGAD, bilateral anterior optic neuritis with optic disc edema involving more than 50% of the optic nerves, bilaterally with optic nerve sheath and perioptic fat involvement, which is characteristic of MOGAD. That is, lesion is anterior to the optic chiasma, involvement of greater than 50% of the nerves with optic nerve sheaths and perioptic fat involvement, which is characteristic of MOGAD, which can be seen in this MRI also. This table summarizes the pathophysiology, the lesions, optic nerve finding in this disease. In Nmosd as well as in MOGAD, we can see that bilateral involvement with greater than 50% of the length of the optic nerve being involved in both of the diseases. In Nmosd, the involvement is posterior to the chiasma, whereas in MOGAD, the involvement is anterior to the chiasma, and optic nerve sheath involvement and perioptic fat involvement is common in MOGAD. Now, come to the myelitis findings in this disease, that is Nmosd, neuromyelitis optica spectrum disorder, and MOGAD, myelin oligodendrocyte glycoprotein associated disorders. In Nmosd, the myelitis is longitudinally extensive myelitis with T2 lesions involving cervical and thoracic cords with elongated ring enhancement. The T2 lesion is centrally located in both grey and white matters. Here we can see that the involvement is in the cervical and thoracic level, and as well as in central part of the spinal cord involving grey and white matters, which can be also seen in this MRI. Whereas in MOGAD, the optic neuritis findings being longitudinally extensive myelitis, that is greater than 3 segments of the spinal cord, which mostly involves lower cervical and upper thoracic segments, as well as cones involvement, which is very characteristic in MOGAD, and there is associated H sign that is restricted to the gray matter and it does not involve the white matter. There is minimal linear enhancement and leptomeningeal enhancement of the conus is also seen in MOGAD. Here we can see the involvement is in lower cervical and upper thoracic level and involves the as well as cones, and involvement is in the central gray matter leading to H sign, and which can also be seen in this MRI. This table summarizes the findings, myelitis findings in Nmosd and MOGAD. In both of the diseases, we can see multiple lesions are common in MOGAD, whereas white matter involvement is more common in Nmosd. Conus involvement is more common in MOGAD. Lens-shaped and heterogeneous parenchymal enhancement is seen in Nmosd, whereas leptomeningeal enhancement is more common in MOGAD. Now come to the brain lesions in the patients with Nmosd and MOGAD. What are the differences in these two diseases in the brain lesions? In Nmosd, the involvement is in the area prostrema, as well as it involves dorsal bones adjacent to the fourth ventricles, which can be seen in the A and B. A is the involvement of area prostrema and B being dorsal bones adjacent to the fourth ventricles. And further, this MRI summarizes the brain lesions findings in this disease. As well as in Nmosd, parenchymal T2 lesions with corresponding linear ependymal enhancement, T2 lesions involving a splenium of the corpus callosum, as well as multiple small non-specific T2 lesions in subcortical white matters. Here in C, we can see that the periependymal linear enhancement is seen. This MRI supports the periependymal lesions which is seen in Nmosd. The involvement of corpus callosum, splenium of the corpus callosum, as well as multiple non-specific subcortical white matters involvement as shown in this figure. And this MRI further explains the multiple small non-specific subcortical white matter involvement in Nmosd. Whereas in MOGAD, the brain lesions include poorly defined, that is fluffy T2 lesions in entire medulla as well as cerebellum, as well as bilateral fluffy T2 lesions in middle cerebellar peduncles. Here in A, we can see the involvement of entire medulla as well as cerebellum, whereas B is the involvement of middle cerebellar peduncles, which is seen in MOGAD. MRI further explains the findings, that is involvement of medulla as well as involvement of middle cerebellar peduncles. As well as bilateral fluffy T2 lesions in the thalamus with prominent leptomeningeal enhancement. It is common in MOGAD. Patient with cerebral cortical encephalitis shows extensive cortical T2 lesions with focal enhancement. B being involvement of thalamus as well as leptomeningeal enhancement, and D being cerebral cortical encephalitis. And this MRI further explains the brain lesions findings in this disease. Then this table summarizes the brain lesions findings in the patients with Nmosd and MOGAD. In MOGAD, cortical and juxtacortical lesions being common, whereas subcortical lesions and third and fourth ventricle involvement and periimpedymal lateral ventricles involvement are more common in Nmosd in comparison to that of MOGAD. Whereas corpus callosum, deep grey matter and diffuse bones and middle cerebellar lesions are more common in MOGAD in comparison to that of corpus callosum, in comparison to that of Nmosd. Ependymal enhancement is more common in Nmosd as compared to MOGAD, and leptomeningeal enhancement and T2 lesions resolutions are more common in MOGAD as compared to that of Nmosd. Then come to the laboratory features in these two diseases. This table summarizes the lab characteristics in both of the diseases. In MOGAD, the antibody positive is MOG IgG, whereas in Nmosd the antibody which is positive is aquaporin 4 IgG. And these in MOGAD, both of these serum as well as serum as well as CSF, we can isolate these CSFs. We can isolate these MOG secreting IgG, whereas Nmosd is not very common in CSF as compared to that of serum. Cell waste assay is the gold standard to test for these antibodies, that is aquaporin 4 IgG or MOGAD or MOG secreting IgG. And qualitative results as well as seroconversions are more common in these in Nmosd, and there is higher risk of relapse in MOGAD as compared to that of Nmosd. On CSF examination, we can have pleocytosis, high proteins and oligoclonal bands, which can be seen in both of the diseases. Then treatment protocol in Nmosd and MOGAD. The main stay of treatment in both of the diseases is to prevent the acute attack, and the second treatment is to prevent the relapses. For acute treatment, we have the options of steroids, intravenous methylprednisolone 1000 milligram for 5 days, or plasma exchange alternate day for 5 to 7 cycles, or steroids, oral steroids of 20 to 40 milligram followed by tapering dose for over a week. So these are the treatment to prevent the acute attack. These are steroids, plasma exchange and steroid tapering dose. Then second one is to prevent the chronic attacks, to prevent the relapse. And for these cases we have affect the long-term prognosis by preventing these relapses. And for these we have the options of complement inhibitors, B cell depleters or interleukin 6 receptor inhibitors. These are more effective in Nmosd as compared to that of MOGAD. The complement inhibitors, which can be used for the management of Nmosd, include equilizumab in a dose of 900 milligram IV every week for the first 4 weeks and then 120 milligram every 2 weeks. or ravulizumab is the other complement inhibitors. Then we have the rituximab, which is the V cell depleters in a dose of 375 milligram per meter squares of intravenous IV every week for the first 4 weeks, or 1000 milligrams 2 doses 2 weeks apart, and then 1000 milligrams 2 weeks apart every 6 months, or inavolisumab, which is also a B cell depleters, can be used for the management of Nmosd. Interleukin 6 receptor inhibitor, that is sertolizumab, in a dose of 120 milligram subcutaneous every 4 weeks, can be used for the management of Nmosd. Whereas these drugs are not very effective in the management of MOGAD in comparison to that of Nmosd. These are in the trial phase. Thank you for watching my lecture. Do subscribe to my channel for more and regular updates on interesting topics of the medical science.